Welcome to Radiologists, a podcast by University Medical Imaging Toronto, where we discuss the most interesting topics through the lens of Canada's largest medical imaging department. I am your host, Satish Krishna. It's often said that it's better to be lucky than to be good. That has never been more true than in medicine, because most of the important discoveries were just strokes of luck. Take radiology for that matter. Röntgen, he discovered X-rays not because he wanted to discover it, he just got incredibly lucky. He was playing around with cathode ray tubes and discovered X-rays. The use of X-rays in therapy, radiotherapy, was also another lucky discovery by Emil Grube. So everything, the use of cinchona for malaria, the discovery of penicillin, all of it has been marked by lucky observations, which were then put into great use. However, that is finally changing. We don't need to be lucky anymore. We make our own luck because now we have theranostics. What is theranostics? What is nuclear medicine? How is it changing the landscape of radiology? To talk about these, we have a guest, another man who has made his own luck. He's the Deputy Chief of Radiology, the Division Head of Abdominal Imaging, and a nuclear medicine physician, Dr. Patrick Veit-Haibach. Patrick, it's great to have you here.
Thanks very much, Satish.
Right, Patrick, so you're an abdominal radiologist and you're also a nuclear medicine physician. How did you end up doing both? Like, were you just tired of seeing black and white images in radiology and you were like, you know what, I need more color to your life, and then jump to nuclear medicine? Because I see that nuclear medicine pictures, you throw a lot of color onto it. Is that why you decided, or how did you end up doing both?
Yeah, it's certainly more fun having more colorful pictures than just the gray and white. I'm just joking. The reason why I did radiology and nuclear medicine goes back obviously to my residency. In my residency in Germany at the time, I did radiology residency, and I wanted to do originally interventional radiology and interventional research. But at the time, and that goes back now quite some years, in 2002, 2003, when I became a resident, PET-CT, so the combination of PET and ACT, the combination of nuclear medicine and radiology, was a hot thing. It was just newly introduced worldwide, and I happened to work at one of the two institutions which had one of the two first worldwide scanners. So at that time, there was an academic need, and because the leadership at the time of the department knew that I was academically oriented, they asked me if I would consider this type of research work, nuclear medicine, hybrid imaging, and if I don't like it, I can still do interventional radiology research afterwards. So I tried it. It was a good opportunity. It was a hot thing at the time, and it was very new. And since then, I kind of quote unquote stuck there because I liked it. I took a deep dive into it, and at some point, I then decided also to do nuclear medicine in addition to radiology.
Wow. So you say that PET was hot then? PET is always hot. That's the only thing which we want to know on PET. It's a radiology joke, guys. Things are hot on PET. So you started from Germany, the birthplace of X-rays, the birthplace of the father of radiology. And I also see in your resume that you were in Switzerland for a bit, the land of mountains and chocolates and fine watches, I guess. And how did you leave all of that and end up in Canada? And how did you make the shift? And how do you like it here?
So first of all, I like it here quite a lot. My family likes it a lot. We're here for 7 years now. So it's a very good place to be, also for the topic we're discussing. How I ended up here, that sounds a little bit negative, but how we came here, it was that I started, as I said, in radiology in Germany. I did that for a number of years. And then I got very much interested in nuclear medicine as well through this research stream. And I thought that I should do nuclear medicine as well. In Germany at the time and in several other European countries, you have to do both residencies. You can't combine it, or at least at this point, you couldn't combine it. So you have to do the radiology residency and you have to do the nuclear medicine residency. And at the time, at the place at the university hospital where I was, there wasn't much opportunity to do nuclear medicine residency in addition. And also, during medical school, I traveled and worked and studied in several other countries as well. So I always was intrigued to go away from Germany again, to go abroad again. And the other very worldwide leading place in PET research was Zurich at the time in Switzerland. So I applied there. This has a little bit of a family background. My wife is a banker, so going to Zurich was also a very good move for her. And so that's why we went to Zurich and worked in Switzerland both for more than 10 years. It was a great time. A lot of technical innovation was happening there. Had very good industry relationships. Did a lot of research, obviously. And even at the time when PET-MR, so the next hybrid nuclear medicine radiology hybrid system came along, we had one of the worldwide first prototypes, and I was leading that project at the time in Zurich in PET-MR. And that was actually one of the reasons when PET-MR development and the development of a PET-MR program was needed here, I was asked if I would join here.
So you came here to develop PET-MR and excellent research, and no doubt you have accomplished both. Patrick, as you know, is one of the leading researchers in our group and established a strong PET-MR practice in Toronto. But what I understand is that you just didn't stop there. You had to then push the boundaries and establish something called Theranostics. What is this Theranostics? I know Thanos. What is this Theranostics and why is it so powerful?
So first of all, I didn't establish Theranostics. Theranostics is in nuclear medicine around for probably around for my lifetime almost. Theranostics is the combination of therapy and diagnostics. That's where this like combination word comes from. So what it means is, and everybody uses the catchphrase, is that what you see is what you treat. So what happens in theranostics very basically is you have a molecule which can detect certain diseases, certain cells. Let's take the example of PSMA. PSMA is one of our radiopharmaceuticals, and it stands for prostate-specific membrane antigen. It's not prostate-specific at all, but it works very well for prostate cancer.
We're bad at naming stuff.
So when we take the case of PSMA, the molecule detects prostate cancer in the prostate, in lymph node metastasis, and distant metastasis. If you label or if you link this molecule with a linker and then an emitter, so something which is emitting radiation, which you can then detect on the outside in a PET system, for example, or in a SPECT system, then you can obviously see the disease, where it is, how widespread it is, how much disease burden there is. If you then change the emitter to a therapeutic emitter, so lutetium in what is currently being used, or actinium, which is currently being used, then you can actually treat these areas which you previously saw on your images. So this is where it comes from. What you see is what you treat. And because we can see, compared to MR or CT, for example, we can see very much down to a certain degree of cellular level. These are now new options in therapies which we can offer to a wide range of patients for neuroendocrine tumors, for example, for prostate cancer patients, for example, where we detect where the disease is and can offer now an additional treatment. It's not a treatment which erases everything else what patients have before, but it's an additional pillar, an additional treatment which we can now use for patients to offer to prolong their life, partly even cure them maybe, and all that with a good quality of life.
So let me see if I get this right. So what you're saying is, in traditional imaging, we are able to identify an abnormality only when it reaches a certain size. Below that, they're too small to be identified. But what you are doing is developing these traces which can identify tiny molecules on a cellular level. So these traces just go and find out that particular cell with that molecule and links to it. And either you put a light bulb kind of thing on it so that it can tell you where that abnormal cell is, or you give it some radiation so that it can literally kill those cells. It's like the ultimate killing machines in which it targets abnormal cells on a cellular level, but it just leaves the normal cells completely fine. Is that what theranostics is about?
This is mainly what it is about. It does not leave everything else alone. It obviously circulates, but it accumulates mainly there what we saw in the images, for example. And there are certain limitations because you have excretion pathways for those radiopharmaceuticals. It's been excreted through the kidneys or through the liver. And there are limitations, obviously, how much dose we can give. Like with every other therapy, there are always limitations, or in general in medicine, there are always limitations to certain therapies, what we're doing. But this is essentially the concept of theranostics, correct?
So even with these ultimate killing machines, there is some collateral damage taking place. So speaking of ultimate killing machines, there was something I wanted to ask you. So you're a radiologist. So radiology deals with radiation, which always has a negative connotation. And then you didn't stop there. You went on and became a nuclear medicine physician, and nuclear, again, does have a significant negative connotation. And finally, now you're involved in theranostics, and it's so cute. It's therapy and diagnostics, but there's a company called Theranos, which recently was just found out to be a huge scam, and I think the CEO is in prison. So you have three specialties, all of which have some negative connotation associated with it. What do you have to say about that?
Well, I have nothing, or we in general don't have anything to do with this company. I don't own any stocks or did not any stocks in that. So we can put that aside. But it's true, in radiology, there is radiation. And from an historical point of view, to a certain degree, it is certainly correct that radiology, the methods which we're applying, will carry a certain radiation burden to the patient. Right? We all know that. The same applies for nuclear medicine, and I think the kind of like bad reputation also for nuclear medicine comes from the word nuclear, right? Because it's associated with in a weaponized context, for example, and also not everybody might be okay with nuclear energy in this day and age. So this is where the bad connotation comes from. However, what sometimes is a little bit tricky, but what we need to emphasize and continue to emphasize is that the test, when we talk about CT as a test, for example, there is a certain very minimal risk being brought onto the patient by this radiation. However, the risk of not having the correct diagnosis and then treating or even not treating the disease in a wrong way, this risk is much, much higher than having the small risk, for example, of radiation. And it always is good for the patient to put it into perspective. So when I prepared for the boards in Switzerland, there was a very good radiobiologist who gave us a script about what are the actual risks and how does it compare to lifetime or general daily life risks which we all have, which we are just not aware. So he compared, for example, the lifetime risk of a fatality of somebody who is 60 is the same than driving 1 hour statistically on a Swiss autobahn, for example. That's that carries the same risk of death basically over a lifetime than being 60 years old. And the
moral of the story is don't drive on the Swiss autobahn, guys.
Well, you can also say you don't drive on the German autobahn because there's no speed limit in general there. But this makes it a little bit more comparable to the patient and to a lay audience. And everybody has certain risks in daily life. When I came here on foot, for example, I crossed several streets. If you don't look at the light, for example, there's a higher risk that you get being run over by a car. Right
in downtown Toronto, even if you do look at lights, you have a good chance of being run over by cars. Let me tell you that. But I think what we need is a better marketing and rebranding, because all of these names, they can be marketed better. You know what? We should ask our producer to find new names for all of these fields.
We should do that.
Ina, can you think of new names for all of this and find better ways of marketing these fields?
Yeah, just give me a week.
All right, guys, let's give her a week. We'll have new names for all of this. Yeah, but on the other hand, maybe you can't rebrand it now because it's already iconic, just like, the CN Tower and Toronto. It would be like rebranding the CN Tower. I don't know how I think about that. Anyways, talking about traces, because I understand that the most important in nuclear medicine and theranostics is the tracer, which can identify those particular cells in different diseases. The question is, how do you develop it and how do you manufacture it? Like, do you sit in your lab and do all these experiments and create them yourself? Or do you just get it out of companies which do this and they provide it to you? How does it work?
So I wish I would be smart enough to create my own traces. I'm not. What's happening is that very special people, radiopharmacists, are creating, or chemists, creating these or building these molecules. So in the last 10 to 15 years, maybe there was quite a bit of push in terms of radiopharmaceutical research. And this is why we are now getting this push in nuclear medicine and in theranostics, because several molecules came onto the market, were partially commercialized, for example, being made available more broadly and widely internationally. And these radiopharmaceuticals are produced in, radiopharmacy labs, for example. So chemists, radiopharmacists, they're working there. They're producing in a highly specialized way these molecules, linking it with the emitters, and then we are getting it delivered. So when we are asking, for example, okay, today we have, 20, 30, 40 patients on the PET-CT with these and these and these tracers, they are figuring out, I have to start producing that usually very early in the morning, actually, to get it shipped to the certain sites or to our imaging facilities at 8 o'clock in the morning, so that the first patient can be injected at 8:30, for example, because there are certain half-lives of those tracers. They don't last all the same time. It has to be very specific on timing, and you have to produce the exact amount in the morning so that it lasts until the time point when it is injected.
Oh, so it's like these Loblaws chicken which you have. The expiry date is that day afternoon. So you can't have the tracers lying around for a couple of days.
No, you can't. So there are tracers which you can have lying around for a couple of days because they have very long half-lives. The usual ones, which are used in normal clinical routine, let's call it that way, they have relatively short half-lives, 1-2 hours, this range. These radio tracers, which we are getting mostly at least, we produce them ourselves in our radiopharmacy. So if you're ever interested, we can, or the colleagues down there can show it to you. It's very impressive. It's like with a clean room and a lot of machineries in there, a lot of robotic arms because you can't reach yourself in there, for example. And a cyclotron is down there as well. For example, cyclotron is a big machine where you fire particles on another molecule, for example, so that it becomes actually radioactive. So you have to go through very thick walls of concrete, for example, to get to the inner core. It's very impressive. So it's like big machinery which is being used to produce those radiopharmaceuticals.
Wow. So you're saying that beneath a hospital, we have a cyclotron, which I don't know, I'm just imagining it as a huge machine which is there. And you have these completely white, clean suits, which you see in those movies and with these robotic arms picking up. So we have all of that and you're producing all the tracers in a hospital. That's really impressive. I had no idea all this was happening behind the scenes. I'm just happy to look at pretty pictures. And good to know that such a lot is happening behind the scenes. So from the way I see it, earlier we were treating the disease. So for example, for prostate cancer, you just treated the prostate cancer or people with prostate cancer. Neuroendocrine tumors, we just treat the tumor. But now from what you're saying, if the neuroendocrine tumor has this particular marker, then you could leverage it and treat it. So neuroendocrine tumors with this marker can be treated different from the same disease without the marker. That leads to an incredible level of personalization, the treatment is specific to the person. So I'm assuming that everybody should be receiving it right now because that's what we want. Personalized medicine, everybody having distinct therapies for their disease, their phenotype. So Is that happening right now in Canada, or what are the limitations, or why is it not as widespread as I would like to have?
So we are treating, and the institution and colleagues and nuclear medicine, the nuclear medicine department is treating patients, for example, in neuroendocrine tumor diseases. There are certain indications which are approved to be treated with this method. And there are more and more studies coming out that even more indications within the same disease, usually it is earlier than in the disease what we are currently treating. There are studies coming out with positive results. So we are expecting to see a significant increase in use of those radiopharmaceuticals for theranostic therapies. In terms of limitations, the limitation is always financing, budget, right? Somebody has to pay for it. It's the insurer or the government. And obviously there are currently talks about how this is going to be funded, how much the hospitals are needing to run a programmatic approach to these theranostics. And also the hospitals have to figure out, okay, how much capacity do we have? How much patients can we treat? How much are we expecting? For neuroendocrine tumors, this is obviously a very prominent disease because it was one of the first indications which was treated with theranostics. However, now coming down the line is, and it's currently being already treated, the first indications with prostate cancer. But now we're having prostate cancer, which have obviously much higher numbers of patients who need a treatment. So at this point, there is discussion with the government, which hospitals have enough capacity, what would be the funding. All these discussions are going on. It takes a while, obviously, until there is a conclusion and a compromise, because we want obviously as much as possible. The government and the insurers wants to give as less as possible. That's the usual thing, and that's not a bad thing either. It's just the normal way things are going. And on the other side, it needs also approval from the authorities. Not every indication is yet approved. Maybe there are already positive study results, but it has to go through the authorities. It has to be proven that it's beneficial, and that always takes some time as well. That doesn't take much longer in Canada or anywhere else. It's just a process which every country, every legislation, every jurisdiction has to go through. And this is what we are partly waiting for, and we are actively working on it from our side, from the hospital, from the physician side, together with the government to get this to patients as fast and as much as possible.
So, as you're saying, as with everything else in life, the biggest question mark is always money and, I guess, bureaucracy for those approvals. And that's why we are really happy to have you here, because as I know, you're doing so much in terms of research and bringing out huge papers and bringing up evidence so that then all these authorizing bodies can approve of all of these markers. So the very basis of nuclear medicine and theranostics lies on these markers. What do you think is the most exciting future opportunity in this? And we're all talking about AI coming up in a big way. Does AI have anything to do with this field overall?
So for the first part of the questions, what are the most exciting things that are coming up? There's a large pipeline of molecules currently being evaluated in phase 1, 2, 3, in terms of for which diseases these molecules could be used for theranostics. So in the diagnostic pathway as well as in the therapeutic pathway. So I would say for the next 10 years, theranostics is a great topic to be academically. There will be a lot of trials in certain diseases. So neuroendocrine tumors is one of the biggest diseases which we are currently treating. Prostate cancer is the next very big disease which we are treating. There are therapies coming down the line for hepatocellular carcinoma. There are therapies coming down the line for breast cancer, for pancreatic cancer, for several other diseases. So there will be more and more options being offered to patients at certain stages of their journey through this disease, where theranostics will play a role. That's not all there yet, but again, within the next 10 years, we will see a lot of results. We will see a lot of studies. And again, if somebody out there is right now in training, theranostics, nuclear medicine, that's the place to be currently. It's very exciting. And for the foreseeable time, it will be very quickly, almost exponentially growing field in molecular imaging in nuclear medicine. In terms of AI is being used more on the preclinical side for development. So to test out these molecules where they fit, for example, and in which cells they would, for example, they accumulate. So you can reduce the preclinical experiments and then run AI experiments, for example, to see, okay, if this molecule really would fit within this pathway of disease, because there are several pathways which we are treating. Some molecules are being integrated into the cell. Some molecules are marking a receptor. Some molecules are marking not only a receptor, but the receptor then changes and initializes a different pathway, which we are then visualizing. So there are several pathways in theranostics or in nuclear medicine, molecular imaging in general, which we will look at and which we will diagnose and which we are then treating. And for the preclinical evaluation and preclinical development, AI certainly already plays a role to reduce the actual animal experiments, which are partly still needed, and on other levels as well, to bring it quicker also to approval.
Right, Patrick, you made nuclear medicine and theranostics so enticing for everybody. I have one question for you. It's probably the last question. Looks like all women want to be with you and all men want to be you, but how does one get to be you? How does one get to do not just medical imaging, not just radiology, but also nuclear medicine, but also take part in this revolution you were talking about, in which there's going to be exponential growth in identification of these traces, which can not only be useful for detection, but also for therapy, so theranostics. How does one get to be you?
So I'm not sure if how many people really want to be me, and in terms of how many women want to be with me, you probably have to ask my wife, and she will give you a lot of reasons why you shouldn't. Right. So that's one thing. Putting that aside, how to get into nuclear medicine and theranostics? That's easy. Obviously, you train in a certain program, and you do your nuclear medicine training, and in a full nuclear medicine physician training, there would be theranostics integrated. As for my part, as I said in the beginning, it was a little longer for me because there was no integrated pathway, so I had to do both residencies. So that's like formally 10 years of training. So you can do that. It's not necessarily advisable. It's a very long pathway. I enjoyed it. But I think there are smarter ways currently, because there is a need to train a new generation of physicians who can use this, use a theranostic pathway. And we are actually currently also here at our department, together with the colleagues from radio-oncology, we have developed a radiotheranostics fellowship program, for example, which you would then do in addition, let's say, to nuclear medicine training, to your regular nuclear medicine training, to focus a little bit on more theranostics. There will be others, let's say, from the radio-oncology pathway, or maybe even from the oncology pathway, who want to be trained in that. So we probably have to refine a little bit our theranostics fellowship for multiple entry points, because, again, it is diagnostic and therapy. So if you're coming from oncology, you don't know maybe as well how to read CTs, PET CTs, for example, as a nuclear medicine physician, whereas a nuclear medicine physician has some training already in some of the therapy application and the diagnostic pathway. So there needs to be a little bit of refinement in terms of entry points and what needs to be specifically trained for those people. But I think a lot of programs are currently being developed internationally, North America, Europe, where I know certain colleagues trying to envision those programs and try to establish those programs as well. And so that's probably the future in theranostics, having an additional fellowship in that stream. Again, as I said before, the next 10, 15 years will be very exciting in nuclear medicine, in molecular imaging, and in theranostics. So I can encourage only everybody who has remote interest in that to apply and to go into that into those residency programs. It is a great mixture of diagnosis and therapy, having patient contact, doing the actual therapy, following up those patients, but have the full breadth of the diagnostic pathway as well.
So what Patrick means here is that he took the road less traveled. he did separate residencies in radiology and in nuclear medicine. But now, what he's doing is he's establishing pathways for all of you, no matter where you are in your training, residency pathways, fellowship pathways, so that you can be a part of this revolution. What's very interesting here is that radiologists have always been behind the scenes. We were always brains behind a lot of decision making, but we were never truly in the limelight. But things are changing. Look at us now. We are right in the limelight. We are coming to the forefront. And theranostics and nuclear medicine, it's going to get us there. Because instead of just viewing images, viewing diseases after they have become big enough, now we are able to detect them when they are very, very tiny at the cellular level. We are able to treat them as well. And that's what brings us to the forefront. So if you want to be a part of this revolution, get on board to nuclear medicine and theranostics. Ladies and gentlemen, that was Dr. Patrick Veit-Haibach, nuclear medicine physician, division head of abdominal imaging, as well as the deputy chief of radiology of University Medical Imaging Toronto, and me, your host, Satish Krishna. See you on the next one. All right, boss? That went very well.
That whole first one, wasn't it?
It's like the naturals.